Yes. Okay. Good afternoon. And yes, we're both here today, so that's good. And I'll just have a couple of comments. Most of the you've heard today is about the framework, about reopening the province, and we've had lots of meetings last week and over the weekend with our counterparts across the country, as each province is doing something similar to this, and so we'll talk about that afterwards. And more importantly, let's go to Dr. Yaffe and see how our numbers are doing, because over the weekend we did have 2 days where we sort of came down slowly from some other levels, so that was progressive, and we'll see how it looks today. So over to Dr. Yaffe.
Thanks very much. So good afternoon, everyone. As of 4 p.m. yesterday, there are 14,856 confirmed cases of COVID-19 reported in Ontario. This is an increase of 424 cases, or 2.9% increase from the previous day. So the increase each day has been going down for the last 3 or 4 days, which is good. About 57.5% are female, 44.5% 60 years of age and older, and 60% are residents of the Greater Toronto Area. I'm very pleased that approximately 57% of our cases have now resolved, which is 8,525 Ontarians. While these are very encouraging numbers, we have to continue engaging in physical distancing and remaining at home as much as possible. In terms of hospitalizations, currently 945 people are in hospital, including 241 in ICU. Unfortunately, we do continue to see deaths related to COVID-19. To date, 892 deaths have been reported, and we have an increase of 57 compared to the previous report. Long-term care, we continue to watch very closely what's occurring in long-term care homes. And as reported by the Ministry of Long-Term Care, we now have 150 long-term care homes in active outbreak. 671 deaths have been reported among residents, and 1 death in a staff person. Healthcare workers, we have 2,016 healthcare workers who have tested positive. This is cumulative, not currently positive. And going back to the hospitalization numbers, again, 945 in hospital, 241 in ICU, and of those, 191 on ventilators. Laboratory testing, total of 242,188 tests have been completed. We have 5,001 currently under investigation, and 12,550 tests have been completed in the last 24 hours. So I'll turn it back to Dr. Williams.
Great. Thank you, Dr. Yaffe. And as I said, the focus today was on the release of the framework. And remember, it's a framework, as I say, not an actual formula or menu at this time. And I said this is consistent, which we have been discussing with our counterparts across the country, as each one is seeking to put in the ideas that we have agreed upon in that, knowing that we have a situation that's a little bit different in each province and territory, and each one's going to approach some things a little bit differently based on their unique metrics and numbers at the time when they make the decisions in that. Generally, most are putting out a broad framework with this idea of the 2 to 3 week stepwise process that once it starts to initiate, to do reviews in that time to assess or test whether the measures have had effect, or in fact whether some of the measures and metrics have actually returned and gone up higher in that ground, and you may have to hold for a while to correct that one, knowing that the dynamics in each province is slightly different and the times and changes will have to be taken into consideration. So this lays a framework for having the public health measures table and others, as well as our federal counterparts and our fellow CMYs across the country, to look at how we're monitoring this situation, because this is a pan-Canadian type approach as well, but here this focuses on what Ontario wants to do and the direction and ideas around that, which the Premier and various cabinet ministers have already spoken to today about. So with that, I know there's some questions, so we're going to hand things over to questions with media. Thank you.
Okay, we'll go to the phone lines.
Your first question comes from Sean Jeffords with the Canadian Press. Please go ahead.
Good afternoon, Dr. Williams, Dr. Yaffe. I'm wondering if you can help us even narrow this down a little bit more in terms of where we are in this framework. I know the Premier is very careful not to lay out a timeline today, but when Dr. Yaffe talks about the decrease in case numbers, I'm wondering if this means that we are anywhere from a week and a half to 2 weeks from a point where we could begin to implement some of these new phases.
So the the concept here is that right now we're in the pandemic phase, and we've had our modelers talk about ideas of where we might have peaked in the ICU and the ventilator type usage. As you know, that's sort of plateaued, and you're seeing a little bit of increase even today, but that means it doesn't go abruptly down. We've talked about that our testing numbers are still quite very high, and they have to come down substantially, and to see that they'd have to progressively go down over a 2-week period to a better level. And we're going to ask our experts on that and our public health measures group to look at the various metrics to say, are we at a stage when we can start to engage in the first phase of the first 2 to 3 week period in there. So this is all saying, here's how it will go. Right now, we're still in the pandemic phase. We still have numbers well over 400. We just came out down below 600 and 500. So we have a ways to go before we get to start our first 2-week period in that light. And of course, we're in the midst of another peak in our long-term care facilities as well. So we're trying to handle that, and we're trying to assess concerns with our congregate settings, be they our ones in prisons or in our homeless populations and shelters and other ones of concern. So we're still very much in the thick of dealing with these various venues with our vulnerable populations and to bring those under control. We've expanded our testing capacity in many ways, heading up, we think, up to 20,000, doing a lot more testing in our long-term care facilities, as well as widening the definition of signs and symptoms that our assessment centers can consider testing the public in. So we're really doing a major ramp up in testing and to see where we are at in order to advise our public health measures group as well as our modelers. Do we have all the data? Are they getting enough that they can say, look at the metrics? Are we ready to start into the recovery phase? Yes or no, and to advise the Premier, the Minister, and the rest of the Cabinet accordingly. So that's where we are at this moment.
Okay, in the interest of time, we're going to move to the next question.
Your next question comes from Allison Martell with Reuters. Please go ahead.
So we're tracking some large workplace outbreaks in other parts of Canada, and I'm wondering what, if anything, would trigger a factory or other workplace shutdown in Ontario? Is there something about number of cases, or do you even have the power to do that?
So what you're looking at there, and I'm going to let maybe Dr. Yaffe want to comment, if you're then saying if you have an outbreak in a large institution in our province, and this, whether it's COVID or there's other reasons we have outbreaks too, in that, what would be a public health response at a local level? And because of the difference between us and the other provinces and territories is that we have powers and authority within local medical officers' health to, with their staff, to handle it accordingly. So I'll let Dr. Yaffe comment on how it works here in Ontario.
Sure, thank you. So certainly the local medical officer of health does have the power to order a workplace, or actually any other facility, basically closed under the Health Protection and Promotion Act if they have reasonable and probable grounds that that is a necessary measure to control the spread of infection. Now, it would be the last measure. We don't usually go there unless it's absolutely necessary, nothing else has worked. So obviously the local health unit would be working very closely with the workplace around, identifying cases, making sure that cases are isolated, stay at home, contacts are identified quickly, and also told to stay at home and watch for symptoms. So active surveillance, good infection prevention and control, screening, all those things in place. If that isn't enough and it's continuing to spread, absolutely yes, closure is an option.
Okay, we're going to move to the next question.
Rob Ferguson with the Toronto Star. Please go ahead.
Yeah, doctors, hello. I'm wondering at what stage we are going to get to a point where public health units will have enough people to track things, or 90% of cases within 24 hours, because the number of cases that are still basically a mystery has been lingering in the 40s and has only recently just come down to the 30s and is now at 35%. So more than one-third of cases still don't seem to be known. How far behind are they, and how long will it take for them to get caught up to the point we need to be at?
Mm-hmm. Well, that's excellent. That's one of the ones we put in here as our metric, and we're working hard at that. With saying, because we had a whole influx, especially after the around the March break period, if you may, and then we started seeing that rise, as you noted, in the so-called community spread, as well as the ones that not enough information was gleaned in that, and some became trying to keep up with that task and keep the case contact manager going. It is our priority to get that back up and to get it running. That's why we did the social distancing. That's why we are doing the physical distancing, because if you separate and everybody does what they're supposed to do, you should disrupt that community transmission. Then as the numbers drop, as they should be, because you're not being exposed, you should be able to see the positive cases drop and drop and drop over a 2, 3, 4 week period. While that's going on, we're continuing to ramp up our base with make sure that our public health people have the resources they need, both when technical supports as well as staffing and data entry, et cetera, to go and do that intense case contact management that is required. Because when you have a case, you have to go and pursue a number of people around there, and that does take time and energy to do that. And if you find someone who has signs or symptoms and you test that person, then you have to do all the contacts of that person. So that is what we have to really have in place, especially as we come down and go into the let's say we possibly go through the downer side in the summer, and throughout the fall we have to have a very strong case contact management system in place with all our health units. So two things happening: ongoing social distancing to allow that type of transmission to stop, and at the same time ramping up the public health resources in order to do that task on a go-forward basis. And when we meet, we should be able to capture back into a containment mode.
Next question.
Your next question comes from Mike Crawley with CBC News. Please go ahead.
Hi, doctors. I'm wondering what we know about how people are getting infected with COVID-19 now, given, setting aside obviously the cases that are happening among healthcare workers and long-term care, how are people in the public actually contracting COVID-19 given all of the physical distancing measures that are happening? Do you have any sense of that?
Well, that's my question, and we're trying to get that down with the case contact management, because when you're correct, if everybody's doing as they should be doing, then now the numbers should be dropping fairly significantly. We do have our outbreaks in the long-term care facilities, some in our retirement homes, and we're working on our congregate settings. So that's a separate issue there, and that's an ongoing one we're trying to deal with separately. What we do find is when we do interview some people is that some have still decided to violate that physical distancing. Seemed like a benign thing to do, to get together in a group behavior in that. Some feel whether they've gotten tired of doing that or whatever, and it becomes their attention that someone later was identified as now a positive case, and they didn't know at the time, they were assured it wasn't, and they start getting spread among that time. So I think we're still dealing with some individuals who are not adhering strictly to the social distancing and that, and choose to say, I don't think it's, at this time, it's not a big thing. And then it does happen, and then people find it's more of a problem. There is still some ongoing within, say, a family unit at times, and we're trying to follow that. But what you raise is what I really like to know when we get back to our intense case contact management, because you got to get it from somewhere. And sometimes people have enough trouble remembering what they did 3 days ago, let alone 12 or 13 days ago. So you have to do a lot of interviewing and re-interviewing. And sometimes people remember, oh yes, I forgot to tell you, 7 days ago I was somewhere. And we also want to know other settings, like maybe some of our essential services that are doing the right things in that, maybe they're not maintaining that. And so is there a setting that has had a breach? And so the question you're asking is one I'd like to know, and we want our health units to know, and we want to get back to that, and that's what we have to address if we're going to contain it in that regard, to know where all the epidemiological linked cases are from, and to deal with them accordingly, wall them off and contain them in that, and get away from all these so-called community transmission cases.
Next question.
Your next question comes from Colin DeMello with CTV News. Please go ahead.
Hi there, Dr. Williams. The document today that was released by the government talks about the importance of childcare to restart the economy, but it's not mentioned in any one of the phases. So I'm just wondering, where does childcare and the resumption of childcare factor in? Would that be a phase 1, phase 2, or phase 3, in your opinion?
Childcare is a very important one, and I'll cover it with a couple things. Remember, we already have some child care services open now for essential workers, and the Ministry of Education, because a lot of them are in some of the settings, have just expanded that to a larger definition of essential workers. So, and we're watching that to say, how's that being done? There's guidelines in their webpage of how that's undertaken, including proper personal hygiene, the handle of the children, etc. in that. And so we want to say, is that going well? The other thing is that Dr. Yaffe talked about on a previous one, and we've done at our federal level, looking at how much children do or don't play participate, I should say, or play a role in the COVID-19 outbreak. And so far, that indicates a fairly limited and small role in that. And so we want to be appraised of that. And then if we're going to start to do that and expand on that, especially if you're talking with child care centers, to make sure that are all the things in place, and looking at those guidelines that are in the Ministry of Education webpage is a good one to see, and other ones that want to emulate and do that, so that in a sense, on a go-forward basis, they would not become a source of transfer, because you may have some adult workers in there who may have gotten infected and can transfer to children who could, in a very short period, transmit it, but they're not known to carry it very long or to be highly significantly ill in that basis there. So it'll be almost very deemed to be almost asymptomatic. So we want to be careful about that and not opening that vector up as another source in there. So it's not particularly in the document here. Some is going on now. More information is coming forward across the country. All the various sectors are asking about schools, school children, and daycare and childcare, and so it is being addressed at this time, and everybody's trying to think what is the right time and way to introduce it when you have a low enough transmission level, I'm going to use the R naught number, and you can say that you have contained it and can handle that way accordingly.
Next question.
It comes from Cynthia Mulligan with City News. Please go ahead.
Hello, doctors. Last week, Dr. Williams, you mentioned that you would like to see the community spread cases drop to well below 200 a day before you would even consider opening up. Can you verify what that number would have been today if you take out long-term care?
Yeah, we're trying to work at separating those out in that number there. And I mean, we're still, it looks like with the 400, still 50-60% of the numbers tend to be around communities. So we're at least up in the upper 200s, if not close to 300. And then in the long-term care ones are varying a little bit there. The exact number are, that's where we're really driving at our data people to say, can you segment those? Can you give clearly which ones are which in that? If we add the congregate testing in on that, does that count or not count? Because they are in the community in that sense. So we want to make sure we're monitoring that correctly. But as I said, we're up in the 400s. Even if you take half that's 260, 270, 280, we have a long way to go to get down to some reasonable level where we can start to implement the first phase of the framework. So, yeah, we got to get to first base first, and we got a ways to go to get down to there. But we're going to try and get those numbers for you, and knowing them from our measurement group to say, well, like some provinces say, you have to have 3 to 4 weeks of steady downward trending, and then some are talking about, well, you want to have no cases for a number of days or a very small number. And so we're going to be asking that public health measures group to say, when is it? When are we convinced that, one, we don't have widespread community transmission? Do we have good containment, yes or no? And a number of metrics to say, okay, let's start rolling out, let's do it with phase 1, and to advise the Premier and government accordingly. So all part of the process as we move forward, and we're working aggressively at that.
Next question.
Your next question comes from John McGrath with TVO. Please go ahead.
Good morning, or good afternoon, doctors. There's a lot of different metrics in the framework as released today, and I'm just wondering if you could give the public some sense of how rigorously a decision to start reopening the economy to move into that stage one is going to rely on hitting, absolutely every metric, or is this going to be something that is balanced? I mean, if we go one day in 28 without seeing a decline in caseloads, does that reset the clock? Can you give us some sense of that?
Yes, I've talked to our public health measures group and at the national level too with our counterparts, and it's more important the trend and the direction. And you're right, if there's a little blip, does that really mean that much in that sense there? And asking our group and our experts, because we want to have it data driven, but that's in the context of the time and the setting with all these four we put here: the virus spread, the health system capacity, public health capacity, and incidence tracking capacity. All those coming together, are we in the right place to say, let's proceed? And then we watch it for 2 to 3 weeks and say, did we continue the downward trend, or did we actually start going up again? And do we have to then stall and wait there for a bit longer to see if we can correct that? So not one single metric, and so one won't throw us off the track either, unless it's really a huge one. Then we'd have to look for an explanation what happened, and that may be an outbreak or something, all of a sudden a large area that we picked up on that, and that would say, okay, is that a localized one? And even though there's a fair number of cases in that locale, the health unit has contained it. Does that affect the overall provincial impact? And the answer is no, it shouldn't. So there's a lot of things to play in there. So I would agree with your point. It wouldn't bounce on one. It would depend on the context of what those numbers meant in light of the containment and the virus spread and containment process.
Okay, next question.
Your next question comes from Phil Perkins with CHCH News. Please go ahead.
All right, thank you, doctors. I was just wondering, obviously a big chunk of our new positive cases are coming from long-term care homes. How much of our decisions to move into stage one going to be based on what happens there? Because from what I understand, they're the front lines, whereas community transmission seems to be going down.
And yeah, those are points I've been making, and we've been asking our data people to really segment those two groups out so we can handle it. One is an outbreak mode. Meanwhile, of course, some of the staff are from the community and go back into the community, including some of the essential visitors go in and out. So we want to make sure that that's not going back from the long-term care out into the community. So that still has a community impact potentially, and we want to make sure that does not occur in that sense. So you're right, if we can get those two separated, and then because you haven't gone into yet when we start having some issues with congregate settings, for example, say in some of the homeless shelters or other ones, because they're much more intertwined in the community, but some other congregate settings are not. So how do we present that in a way that monitors the overall picture of transmission in most of the regular citizens of Ontario as compared to in unique outbreak settings such as long-term care facilities, as you've alluded to?
Next question.
Your next question comes from Morgan Campbell with Global News. Please go ahead.
Thank you, doctors. I wanted to touch a little more on the school system. If you're saying that kids are somewhat asymptomatic or believed to be, can you explain maybe when we expect schools to open, and is it realistic to think that June 1st may be a potential date, or should we really be looking forward to September? And just to kind of compound on that, how is day-to-day face-to-face learning going to change for kids moving forward?
So that's a good question. When we've had, and we'll have ongoing discussions with the Ministry of Education, with the minister and with the deputy and staff in that. And what we're trying to say here is if we have still a fair amount of community transmission going on, we know that children can be positive in some transmission from their parents or in the close family unit for a short period of time. If the parents have become in contact in a community spread type situation and are incubating slightly symptomatic and pass it on, that means the child can go into the setting, and especially if balances and checks are not put in place in that one that allows a vector for transmission, then it can go to quite a few children. They go back out and they contact the parents, and the parents get it, and then you're seeing a whole outbreak in the community writ large again. So we don't want that to occur. So we have to make sure we have a low enough community transmission to say, so what's going to happen between now and the end of May? We're going to really watch these numbers and to see if we're going to get into that process of the steady 2 to 3 week decline. I mean, it'd be nice if it came down really fast, but I can't say that.
Okay, I would encourage others who haven't had a chance to drop into the queue if they're willing to. We're going to move on to the next question, which I believe now is our last question.
Your final question comes from Jessica Smith with Queen's Park Briefing. Please go ahead.
Hi, doctors. We're looking into a story that shows that the worst outbreaks in Ontario have occurred in nursing homes that are older, that still have 3 and 4 bed wards that are actually quite small rooms. Are you concerned about the state of the actual physical buildings of Ontario's long-term care homes?
Thank you. There are, many factors that contribute to outbreaks. And in long-term care facilities, certainly the fact that you have a vulnerable population living in a congregate setting by itself is a risk. But the physical outlay of the long-term care facility can very much be a contributing factor, because if people are close to each other, as we all know, that contributes to infection spreading between people. So, but there are other factors as well. But yes, the physical outlay or the way it's organized is a contributing factor. And I think at the end of this situation, I think there will be an opportunity to review what happened, what contributed to it, and what can be done to improve the situation.
Okay, thanks everyone.
Thank you.